non-cardiac surgery. Yeah. Yeah. Yes. Clopidogrel, after 1 year, you can discontinue as long as a week. We have to continue both of them, unfortunately. Yeah. Now, going to structural heart disease, we have one patient now. I'll just go forward.
No, just one question, Dr. Ponde. Yeah. If it's more than 1 year with a drug-eluting stent, which is a safe time when you think that aspirin can definitely be stopped? Is there a zone like after a stent, 1.5 years later, you can stop it for a few days and restart? Is there
I'll tell you, 2 years is the cutoff where even both can be stopped very, very safely.
Okay.
2 years is the cutoff where both can be stopped very safely. After between 1 and 2 years, clopidogrel can be stopped safely.
Aspirin
and if you have a high-risk patient, let us say a patient who had 3 stents in 3 major arteries, then you are thinking. And if the patient has 1 stent in an obtuse marginal branch of a circumflex, fine, that's fine. 3 other arteries are good. But if you have 3 stents in 3 major arteries, then what we do normally, I was telling with Dr. Bala yesterday, that we start the patient on a short-acting platelet receptor antibody called tirofiban infusion after stopping clopidogrel. Then discontinue infusion 12 hours pre-op, let the surgeon finish his surgery, start the infusion again 12 hours post-op, and continue for at least 12 hours later. So that the critical period of stent thrombosis is taken care of. And then you can reinstitute clopidogrel 48 hours down the line. Okay. That's what we do. Yes.
From what we have discussed, we come to a conclusion that somebody has a drug-eluting stent for 2 years, since he has to be on aspirin at least 150 milligrams. We can't put in clopidogrel for 2 years. Can we make a conclusion from what we have discussed?
No, that's a very big statement to make because, quickly, I know that it's very important, this point, and then there should be a consensus on what has been discussed. See, actually, I've got the ASRA guideline. I'll just read one statement. Incidence, risk factors, and neurological outcome of spinal hematoma. Spinal hematoma, defined as symptomatic bleeding within the spinal neuraxis, is a very rare but potentially catastrophic complication of spinal or epidural anesthesia. The actual incidence of neurological dysfunction resulting from hemorrhagic complication associated with central neural blockade is unknown. And in an extensive review of literature, TIBRA defined 13 cases of spinal hematoma in 850,000 cases. This is the study based on which they came to a conclusion of 1 in 150,000 and 1 in 1 lakh in 20,000. And then finally in this statement they conclude, at present, it's very difficult to define what will actually happen to the patient. So what actually, because you raised this point and it's a very important point, the consensus could be, if the same thing which we discussed with general anesthesia and regional, the question comes only when you want to use a central neuraxis blockade. So it's purely left to the anesthesiologist to decide which one they will use based upon the infrastructure that is available. If they think that majority in the private work, if you give a general anesthetic to a geriatric patient like this, whether life will be safe in comparison to a possible development of an epidural hematoma, vis-a-vis a pro and con between you, and you need to decide.
All right.
Yes, Dr. Murli.
Well, I kind of beg to disagree with your statement, even the one you made on the stage yesterday. The take-home message is not that you make a choice. Even ASRA is sitting on the fence and saying that it's very difficult to say. So if I get an epidural hematoma in a patient with a drug-eluting stent, and if I call you as an expert, I'm sure you'll say that.
No, sir, that's why. No, I know what you're trying to say, but what I'm trying to tell you is, when we decide on doing it, eventually the point was the patient has to walk home, number one. Number two, when we do this, we get a consent and only do this. It's informing, it's a written, informed consent with all consent.
The consensus of this forum, if we change to say that all the parties involved, the surgeons...
Yes, exactly. And that's what even ASRA suggests in its literature. And only one more point I would like to say, which I felt by heart. Yeah, only know that because, we'll discuss in the panel discussion. Yeah. Yes. We'll do it in the panel discussion, sir. I have one more thing which I want to reveal, which we'll do it in the panel.
70-year-old male, admitted with fractured neck femur, and hemodynamically stable, no clinical heart failure, no comorbidities but a sedentary lifestyle. ECG showed left ventricular hypertrophy with strain pattern. Echo shows severe calcific aortic stenosis. ejection fraction 40%, not taking any drugs, and is posted for bipolar hip replacement. Choice of anesthesia, Dr. Bala? Catch-22 situation.
Yes. So again, I think we have come back to the same thing. It's a case of fixed cardiac output. And
these are the choices you have.
Yes. So if you're very, very proficient, I think a continuous femoral sciatic block or a lumbar plexus with sciatic would be extremely good. If not, what Dr. Silamban was discussing yesterday, a segmental epidural where you produce, that was a very nice explanation which was given to him. That's the next option. And of course, always you have a general anesthetic, but then you need to weigh the pros and cons of giving general anesthesia to a patient with fixed cardiac output. So this would be the choices, and based upon whichever you're comfortable with, you can choose. I think we can go to the next slide. Why?
I think the first choice is far better. For a hip surgery,
See, actually, because of the fact that, especially if you're using both non-stimulating or a stimulating catheter with continuous femoral, and if you keep it at about 15 centimeters at the skin mark, it almost becomes the tip in the iliopsoas compartment in majority of the cases. So it's an option, but it's just the option. Then whichever you're comfortable with, you can choose and do it.
All right, Dr. Bala, the next question is, if this patient, let us say, God forbid, develops intraoperative hypotension, how will you manage it?
I think probably the best
This
drug.
patient, remember, has severe aortic stenosis. He has left ventricular poor ejection fraction, meaning thereby the left ventricular end diastolic pressure is already elevated. So how will you manage the intraop hypotension in this patient?
The best thing is I would wish that this doesn't happen, but if it happens, if it happens, I think the best drug that I can probably depend upon is small aliquots of norepinephrine to be given to this patient and keep the runoff less.
I think our choice will be, the first choice will be either norepinephrine or even little I would tend towards or incline towards vasopressin in this patient. Because here what we need is just aortic stenosis patients are already, their systemic arteries are already maximally dilated. Please remember that. So you need something like a small vasopressors to build up their pressures. Volumes they don't generally tolerate, and inodilators they tolerate extremely poorly. So please don't start the patient on dobutamine and adrenaline, for heaven's sake. What will land up with more hypotension and refractory ventricular tachyarrhythmias in face of AS and ventricular dysfunction. So they are the bad choices. Now, we don't have that anymore now, so I have no experience on this molecule at all. Phenylephrine is talking about. Yes.
Heart rate.
Yes. We'll go to the last case now. Now she's a 42-year-old female with known rheumatic heart disease, history of balloon mitral valvotomy 5 years ago. She's in chronic AF and had recent increase in the dyspnea from NYHA class 1 to 3. A 2D echo was repeated which showed a mitral valve area of 1, that is restenosis. Now the valve is calcified and the heart rate is around 100 in atrial fibrillation. Her ejection fraction is relatively all right. Pulmonary artery pressure is mildly elevated. And she's admitted with systemic thromboembolism and left foot gangrene. On admission, a heart rate of 110 AF, blood pressure 100/70, and needs a BK amputation. This is a case. This is a real case. So now, this was a patient. The issues here are control of ventricular rate first. Please remember, do not wheel in this patient without control of the ventricular rate in atrial fibrillation. And by control of the ventricular rate, we mean the ventricular rate of less than 70 to 75. In this patient, it is must to control the ventricular rate prior to surgery, as this is the best guarantee to avoid pulmonary edema intraop. Best drugs are, please remember the patient's blood pressure was 100/70. So beta blockers, even Dilzem for that matter, is a borderline bet. So the best drugs are digoxin and amiodarone. Second important issue in this patient is, would you like to anticoagulate this patient preoperatively? And what anticoagulant? In atrial fibrillation, 5% of the emboli, 9% of the emboli are systemic, the rest are all cerebral. And going ahead, 10% are fatal and the other are distributed into mild and moderate. So this is a moderately severe episode of systemic embolism in this patient. The next episode could be cerebral, which is more frequent. So there is no question we have to anticoagulate this patient. You cannot wait for the surgeon to finish his surgery and then most of the surgeons will tell you that. Let me finish my job, then you give heparin. For that, there is a big no, capital underline 10 times. Because the patient may come out of the surgery with a stroke. So you have to anticoagulate, and here the choice is not low molecular weight heparin. In fact, this is one indication. Cardiac source of embolism is one indication in literature where there is no data whatsoever on low molecular weight heparin. The data is robust on conventional heparin, where you have to use bolus plus infusion and maintain the PTT around 2 times the control. Discontinue your infusion around 4 hours prior to surgery so that even you can give on a central neuroaxial block without a problem. What is the choice of anesthesia?
Yeah, actually, you mentioned that if you use this one and if you stop 4 hours prior to that, I think it...
Sure, yeah. So here the combining central neuroaxial techniques with introp, this is the ASRA guidelines 2009. Heparin administration should be delayed for at least 1 hour after the needle placement. Indwelling neuroaxial catheters must to be removed 4 hours after the last heparin dose. Reheparinization minimum 1 hour after the removal of the catheter. Monitor patients closely 48 hours later. These are the 4 important points for unfractionated heparin for central neuroaxial blockage.
This monitoring
and
essentially means neurological...
yes, neurological monitoring, absolutely. Yeah, neurological monitoring. So this is what it is. I think we can skip this case now. We are overshot the time. Fallous physiology. So I think, ladies and gentlemen, we have some few cases, but I will just summarize.
Sir, in that case, probably I think you can just enumerate the highlights, the 3 points. IE prophylaxis,
Yes.
Therapeutic phlebotomy.
Yes.
And I think that alone you can mention
Yes.
and then we can stop.
We had a case of tetralogy here who had, tetralogy who had avascular necrosis of neck of left femur head, came for surgery, and her hemoglobin was 19. The issues here are infective endocarditis prophylaxis, must phlebotomy to reduce the hemoglobin.
So what is the current thinking on IE prophylaxis and what are the current recommendations?
No, see, this is a high-risk lesion for infective endocarditis. So there's no question. In this patient, it is indicated. In the previous 2, there are gray zones now, as for the 2009 guidelines.
No, what were the drug of choices in this patient?
The drug of choice, there are 2 drugs of choice in this, 2 regimens of choice, amoxicillin gentamicin combination, or Reflin and Genta combination, or a single dose of vancomycin 1 hour before.
Especially in patients who say they're allergic to penicillin.
Yes.
And because cephalosporins also sometimes
Yes.
we can't use.
Then
so
vancomycin.
Vancomycin. And what would be the dose that you would
usually
advocate?
around 750 milligrams to 1 gram, diluted in 100 ml of normal saline, slow intravenous 1 hour before.
Yeah.
Yeah. So we'll summarize by saying that anesthetists in the operating room carry on their shoulder or this much of burden from all the sides. But please remember that for most surgeons, following things in preoperative evaluation are either illusions or mind games played by anesthesiologists. Electrolyte imbalance, low hemoglobin, abnormalities in blood gases, ECG changes. What are ECG changes? Comorbidities. And when we talk about risk scores, they make face as if they know nothing about it. And they sincerely believe that once they obtain a so-called high-risk consent, the risk decreases automatically. So, ladies and gentlemen, most often than not, after such an argument, we land up in this kind of fights. But I must say, surgeons will have to change their attitude. Thank you for your patience.
Excuse me, sir. One question.